Dr. Yip. I've been practicing for about 20 years, 20 plus years. So my experience is in, I think all the types of ICLs that's available in Malaysia. We started with the Swissmed ones, then the iCrill, and then the IPCL, and also Medinium. All of them are implanted, all right? Today we're going to talk about IPCL, all right? Okay, first of all, this is a very exciting topic. Why? Because I see many faces looking quite with a lot of interest. You have a valid reason, because why? Let's say you're a surgeon, a beginning surgeon, you have your own center, you want to start refractive. What do? You're not going to spend millions on a femtosecond or a laser, right? So this, I feel, is actually a better solution in refractive surgery than lasers, right? For many reasons. It's safe, your cornea is not damaged, you do not have to, if you have done LASIK for a long time, you know you have to deal with a lot of things that can come back to haunt you much years later, right? Okay. Believe in the next few years, right, it's going to be much more popular, and I'm looking forward to, you can read that, I'm just going to talk along, it's all right. So I'm very interested in the new lenses that they're going to come up with. Dr. Julian, I believe, will talk about the multifocal lenses, right? I myself is interested more in the extended focus lenses, if there's any in development, right? We'll talk about this later. All right. The model for the new IPCL is very agreeable to me. There are many holes that can equilibrate the aqueous between the posterior and the anterior chamber, right? That's a plus, okay? And if you have implanted IPCL for a long time, you understand that this design with the haptic, these knobs, right? They are very friendly to you. If you have implanted other plate haptics, you find that it's very bulky. It is harder to implant because you have to push it to the posterior chamber, which forces the viscoelastic, you have to force a viscoelastic somewhere. So if you have spaces, it can come to the anterior chamber easily, but if you just push it, it's actually harder than you think. Okay? All right, it has a central hole that is, I don't know. I mean, this is what the research say. Conal hole, less dispersion, more light. Okay, it's just a bit different than the Swissmed one. All right. Okay, this is how it looks. All right, there are two holes, two dots that you can align the lens with. It basically means you do not have to rotate your lens in any direction. After implanting, it stays where it is, okay? You just mark where your temporal section is, and it stays there. And if you're going to implant IPCL or INA sort of ICL, I advise you to start with doing temporal cataracts. Get as comfortable as possible with temporal cataracts, because if you're going to try it from the superior part, you have a lot of vascularization, conjunctiva, and you may have a SIA, all right? So I find that anything 3.5 mm and below temporal, there's no SIA, right? I've done the topography on thousands. There is basically no 3.5 and below, you're fine. Okay, these are the type of IPCLs that is available. I've implanted all of them, all right? Okay, well, what is the indication? Basically, anybody above 18 years old. I wouldn't even talk about whether the cornea is suitable or not, because my first choice is actually IPCL. It's just a cost factor. I do not think that changing the cornea, having a flap, or just lasering the anterior part of the cornea is a very good thing. It may be even phased out, I don't know. I mean, there are a lot of companies invested in this, so it's a big industry, so, Okay, let's talk about the contraindication. The contraindication, actually, the first one is the size of the eye, the anterior chamber. We call it the AQD. Aqueous is the ACD minus the endothelium, all right? From the endothelium, right? So for IPCL, it has to be, it's given 2.8, right? Anything below that, 2.7 and above, you actually can, but it's up to you. The onus is on you. They won't say can. You can order it. Anyway, the issue doesn't come because there's another type of lens that you can implant if it's 2.8 and below. It's called Medinium. It's a floating ICL. There's two sizes, so just stick to, I think, 2.75 and above. Okay? I don't do cornea endothelial cell counts. Healthy adults, no disease, what are you going to achieve? History of uveitis, yep. Of course, you have to check the eye first. Everything has to be normal. He has to be a healthy adult, okay? Assessment, it depends on what type of machines you have in your center, okay? You have, look at it, basically, white to white is the most important. White to white determines the size of lens that you're going to order. It's a trial and everything. For me, I measure it with two equipment. One is the NIDEC OpScan, and another is my cornea topography. I can't remember what brand. Okay, it gives different reading, but it is consistent. So one is measuring the white to white a little bit bigger than the other one, but it's consistent. I would know what lens to order. I used to do it manually by calipers, but you know, if you have a busy clinic and you're going to measure it, it's just too tedious, right? Lately, I've been playing with the idea of you know, the OCT machine. You can mount an anterior OCT and can measure this one. Is anybody doing that?
Yeah, manual caliper.
No. The OCT picture.
They draw the line.
Yeah. I think that would be the most accurate. So like Julian was asking, he has some angle closure. The most accurate would be that, right? But for me, mine is good enough. So I have the OCT as well with the anterior thing that you can add in. I think I may start to do that, right? Because why? As you see later as I present, you may have some hit and miss. This is how the calculation looks like, all right? So the white to white, the input is done by you. So for me, I just give the data and then Siva helps me do it, and then I look at it, and then if I see that the anterior chamber depth is less than 3.25, I may make it smaller. And then one of the advantage of IPCL is the graduation is 0.25. The others are 0.5. So it makes sense. You can actually decrease it 0.25 and it just fits perfectly. Okay, let's come to the surgery. Okay, first of all, let's do a temporal. Let's agree on that. The superior is messy. If you want to start, just start cataract and temporal. The incision size, the normal 2.75, it won't go in. You have to extend until about 3. Okay, why I expand until 3? Because you can force in a 2.75. What's the issue? You're trying to make it smaller, you squeeze it, you may create more corneal striae, right? The worst thing is you force, next day you come, corneal striae. There's no point, and some of them doesn't go away. So let's extend it to 3.0, okay? Then you have a side port, okay? Side port, you don't have to be in the center. Side port is near where you are going to be nearest to the leading haptic, all right? Put it near the leading haptic. For me, because I'm left-handed, and when I was young, my mother beat me out of the left-handed, so I'm ambidextrous. So for me, it's very easy, right? I will have my side port just like a phaco. But for you, some of you who are right-handed, if you are using a left hand to manipulate, you may find some difficulty. You can overcome it, but it's not comfortable. Okay, next, I do not use viscodispersive for several reasons. I'm not sure. Next, you can agree or disagree with me and see from experience. Viscodispersive viscoelastic, okay, theoretically it coats the endothelium, it coats the cornea, it doesn't create space. Okay, first of all, what you're going to experience is, if you inject a viscodispersive viscoelastic into the anterior chamber, and you're coming with a keratome, suddenly you may touch the lens. It's nearer than you think. So, you see, this is a perfect patient, no cataract. You touch the lens, what will happen? You're dead, man. Okay? So I use a space creating one. All right, I use Helon GV, something like that. Okay, and then once you go in, I have one side port. You're not ambidextrous, you may want 2 side port. It's up to you. It's just a step incision. It doesn't do any harm. It's not going to kill any corneal nerve or anything like that. All right. Okay. The injection part is the most important. What you have to do is be slow. Be slow. We'll talk about the loading part later. Okay, first of all, what I do is I do not, I load the lens before the surgery, because the preparation is very fast. The patient is on the table, povidone iodine, all right, leave it there. It needs to stay on for 1 minute. While the 1 minute is going on, I load the lens. And then I drape the patient, side port, poop, viscoelastic, go in. Okay, so now we're going to inject the lens inside. Why slowly? Because this lens come out in many forms, right? It can come out like a U shape or N shape or W shape. It can come out in any form, right? Stop if the leading edge stops and it gets folded. If it gets folded and you continue to inject, it can come out. But when it spring out, it will touch your endothelium, it will touch your lens, all right? It should be smooth. Slide it in, the leading haptic, you can see it coming out. Okay, so once the leading haptic comes out and you see the optic halfway, look for the central hole. The central hole should always be the center. If it's at the side, if the lens unfold the other way, you don't rotate it inside the eyes. Right? The next day your endothelium will be gone and your cornea will be white in color, right? You have to just easily take it out. They send two anyway. You can use the same lens or you can use a new lens, right? So inject halfway, make sure the optic, the central hole is at the center, and slowly unfold. And after 3/4 is coming out, you can roughly see how it's going to unfold. If it's the other way around, then you can twist it because it's still in a circle. It hasn't unfolded yet. You can twist any way you like. It's very easy. It's very easy. Just don't let go. Once you let go, you have no control. The last bit, don't let go. Don't let go until you're sure you are vaulting like this. Okay? There are notch left and right to tell you where the vault is. But when you're first starting, you will not notice all this. And just take your time and just let it unfold. Okay? After that, the job is very easy. There's a second instrument which is blunt. Just go for the haptic, tuck it under the iris. Because of my viscoelastic, which is not dispersive, I actually have to use an IA probe to remove it. So I'm just going to put in an IA, just that's it. Right? They have never had increased pressure post-operatively. It's very easy. All right? And you will never have wound leak. Just hydrate your wound. Not really. You come out, I don't know why. These young people, the cornea is very nice. It just closes. Whereas in older people, like cataract surgery, you may sometimes need to hydrate it. But in younger people, you notice, as long as you have a nice rectangle, right, like this, it will always seal. Okay? Okay, so this is recommended, HPMC. It's up to you. I want to hear what the others, how they experience the dispersive type. Okay. Yeah, all this you have. Okay, the one important thing is the dilatation of the eye. Before the insertion, when you go into the eyes, the iris, the pupil may actually constrict, right? And if it's not well dilated, there's a lot of corneal touch. Corneal touch is what you don't want. Your post-op first day, you won't get a 6/6, this, you just don't want to touch any cornea. I actually put in intracameral lignocaine. So that you must mix it with BSS for the acidity and all that. But that dilates the cornea very well, all right? And in some tough cases, you may even add some adrenaline inside, 1 or 2 drops of adrenaline. It doesn't do very harm. It's very, very light, very little. Okay. So this is the blunt instrument that you need to use to tuck in. I think they will. You can advise them on what. Okay. Okay. This is up to you. For patients' comfort, you would want to load your lens first. Especially if you're using those switch smash one, it takes some time to load, right? Because I operate under very low dim lighting and as fast as possible. So load it, pop, okay. The patient is because they're very nervous. That's my timing. Okay, look at the notch. This is how you have it has to unfold like this. Okay. This just comes with experience, no problem. Just the main advice is just don't let go. Don't let go. Don't let go. Okay, this is how it looks like. The loading part, go ahead. It's very easy for cataract surgeons. You load it exactly like a lens.
Use the injector and the cartridge that came with the IPCL.
Okay, so look at the loading. It's supposed to be in.
Put the cartridge into BSS.
Put some viscoelastic, put some water.
The cartridge should remain in BSS for at least 1 minute. This is to activate the coating of the cartridge.
Okay, then put it on and tap the side inside.
Fill the
Tap
tip
the
of
side.
the cartridge with HPMC.
The haptic, the optic, tap the side in.
Use a microscope to load the IPCL. This is the correct positioning of an IPCL.
Yeah, you don't have to look at those notches because it's supposed to be angled this way.
You're facing the upside when the noses are in this position. Ensure this position also.
Okay,
after
there's
implantation
two,
of the
you see the two
IPCL.
holes? They're supposed to be
Position
at
the two openings
superior
at the
part,
edge
superior
of the
eyelid, so that
optic
when you
so
know
that
it
they
closes,
come to lie
it's not supposed to be in the
under the
interior.
upper eyelid.
So when you're loading like this, the patient's like this,
In this
I look at the patient and when I load
the
it, my
IPCL
injector is like this,
loaded
the
for a left eye.
two holes are here. If I'm
Two
doing the left eye,
openings are at
the
top,
two holes are here.
and
That's
the
all,
tip of the
superior part, okay?
cartridge points
That's easy to
the
remember.
left. For a right eye, the two openings should be at the bottom, or the tip should point to the right.
Tap the side in.
Position the IPCL on the open cartridge.
Okay, just
Press
fold it.
carefully with the
You will
closed
fold in an N
forceps
shape, not a
on the
U
middle
shape.
of the
It's going to fold like this.
IPCL and fold it
Not like this.
against its curvature.
You just fold like this.
Close
Just tap the top of the end
cartridge by half
so that it doesn't get caught in
and
the haptic.
ensure
Close
that
it.
the rims of the IPCL are in the cartridge.
Does it matter whether it's N or U? It doesn't, but most of the
Perform
time
a
it goes in the
mobility
N
check
shape.
after closing the cartridge.
See, if it moves, it's fine. If it doesn't move, it gets stuck. You can still push it, but stop.
This
Reload
is
it
to
again. Huh? That's
ensure
when it
that the
unfolds and it just
IPCL
spring and
is
touch the
freely
endothelium.
movable. Inject some HPMC behind the IPCL.
The acryl looks something like this, but it has less holes in it. The medianium is quite a big piece, and
Store the loaded IPCL in BSS until implantation.
okay, it comes out very easily. Temporal, always choose temporal, I should think. I use a Hilon GV. This is how it looks like. It's very elegant. I like this lens. Very elegant. Look at the size of the pupil. It looks like after implantation. Okay, one thing before you remove your viscoelastic, look at the size of the. Look at the wall. Look at the wall. If you feel it's too big or too small, when you first start and your sizing is not correct, you should look at the sizing after the surgery. You think it's not correct, just take it out. Right? So sometimes I have a higher wall, but I think it still works. I leave it in. But the next eye, I will go for a smaller lens. So, no harm done. You don't need to explant, and he's safe. All right? There are pros and cons to being the wall too high and too low. Okay, aspirate OVD. Okay, I've decided to, when they asked me to talk about this, so I just pulled up the last 30 IPCLs that I've done and give you some statistic. Let's go. Okay, it's actually a very safe method. The target refraction is actually perfect. Whatever I present later where I do not get the target refraction is either I've undercorrect them for those presbyopic people, or some of them have some mild amblyopia, because it's like prescribing glasses. It is very, very accurate. It's much, much better than LASIK. All right. The only thing is I will advise you is green more than red. In young people, if you put green is red, they are minus 0.5 in at night. For photopic vision, scotopic vision, there's a 0.5 to 0.75 difference. If you put them red is green or less than red is red, better than green, at night they will not be happy. And this young patient, they want to see things far away. They don't realize presbyopia is coming. So always make them plus 0.25, plus 0.5. Trust me. Imagine even you're older, you're 40 years old. You're neither here nor there. One eye is minus 0.5, one eye is minus 0.75. It's not enough to offset your presbyopia. It's not enough to drive and see a clear vision. Right? Last time I used to think that low myopia is good. You're nowhere actually. So one of the eye achieve ametropia or plus 0.25. All right. Okay, this is the range of most of them are in the 21 to 25 age group. 45 to 50 also got. Okay, can you turn that back? 46 to 50? Do you agree? Some of you may not. I actually don't, but these are people that want it. You counsel them, there's no other way. LASIK, remove the lens. No. They say, hey, doc, I don't want glasses lah. What is the way? You have money? This is the way lah. Anything happen, we'll take it out again. Alright? Range of myopia. I think the range is until minus.
Your highest is 20.
For IPCL?
Minus 30.
Minus 30. Right? Next. Okay, this is a past 31. Most of it is toric lenses now. Toric. Most of them, anything above 0.75, I will correct the astigmatism. With the rule astigmatism, I may go up to, if you have 0.75, 100, I may let it go. But against the rule, just correct it, okay? Okay, multifocal IPCLs. This is the same class as the diffractive ICLs. It behaves exactly the same as a cataract lens. So Julian will talk about this later. I have some experience with this, but we'll talk about it when we discuss it, okay? Percentage of target is almost 100%. All right. So now, okay, next one. Okay, this is the issue. I myself have some sizing problem, but once you get your nomogram, you should be okay. Right? Once you get a nomogram, you need to know that this sizing doesn't apply to all people. You have to look at the AC depth also. Anything below 3.25, you have to be careful. They have actually a chart where you can reduce it or increase it if the anterior chamber depth is smaller or bigger. So they need about few weeks to make you a new lens lah. So actually when I implant a lens, I feel it's too big, I will take it out because you don't want one eye to have this and one eye to have that, right? If I think that it is okay, but it is not optimal, I will wait for a smaller size and implant into the next eye. Okay? Okay, thank you.